Professor Zainab will introduce the first speaker.
Good evening all, and hope you had a good lunch. So we're going to start the breast surgery session now. The first speaker is Dr. Gianologi Loridiana from Italy. Sorry for the maybe bad pronunciation of your name. He's the Medical Director, Oncological, Reconstructive and Aesthetic Synology Surgery in Buzinco Oncology Hospital in Italy. And his lecture will be about clinical application of autologous fat transfer in breast surgery. Prof.
Good afternoon. My warm greetings to Chairman and my sincere thanks to President and the organization team of this meeting for kind invitation. So it's a pleasure to me to be here and talk to you about autologous fat grafting. Okay. A short historical background about this technique. The first attempt to describe, to perform a transfer from another body site to the breast of tissue fat was described by Cerny in 1895. He tried to move a lipoma from flank to the breast. And in the following years, many other surgeons tried to perform this technique, but with very poor results because they encountered a lot of troubles like fat necrosis or infections or hematoma. So we arrived to 1987 when Birkol performed the first autologous transplantation harvesting fat by liposuction to the breast. So in 2007, Coleman described and standardized and feasible technique to perform fat grafting that now is usually known with his name. The application fields of the technique are mainly two: to obtain filler effect and obtain tissue regeneration and repair. This is possible thanks to the properties of lipoaspirate that contains stem cells, several growth factors that can promote restoration of tissue vascularization because of neoangiogenesis. What are now actually the indications in breast surgery of lipofilling? Correction of small defects after conservative surgery, correction of contour or shape deformities after breast reconstructions, improvement of soft tissue coverage following implant-based breast reconstruction, treatment of irradiation effects, and treatment of wound adhesions and scar correction. There are other two indications, such as breast reconstruction and pain treatment, that are in a development phase. Some short notes about this last indication. Breast reconstruction using fat grafting only. Many authors, several authors described it in the last years, often using automatic vacuum systems like Brava system to prepare the recipient site. And this is a study published by an Italian author about lipofilling used as primary, using as treatment of pain as primary indication. The technique may be performed in general anesthesia, well known as dry technique, or in local anesthesia and sedation using Klein solution that consists of normal saline, epinephrine, lidocaine, and sodium carbonate. The fat is harvested from abdomen and or flanks using blunt-tipped cannula of 3 millimeters in the maximum diameter, and with small holes near the tip. After the lipoaspirate, solid lipoaspirate is centrifugated at 3,000 rounds per minute for 40 minutes. Centrifugation may damage fat cells, so it should be restricted at the minimum time necessary to obtain separation of the fat. The separation is performed removing the supernatant that consists of oil produced by the rupture of fat cells, and the bottom layer that consists of serum, blood, anesthetic if we use the local anesthesia. So we can infiltrate the lipoaspirate. I usually prefer to at first use a small cannula only without syringe linked to prepare the recipient site to make space in the subcutaneous space, especially near the scare or around the scare. When we can go to injection, remembering to make several multiple tunnels and injecting a small aliquot of fat every time, because if we infiltrate a large amount of fat, probably we have a liponecrosis after the procedure. I will make something wrong, okay. Without the complication, all size formation, you can see on the right above the classical ultrasound image of all size, hematoma, contour irregularities, fat necrosis, seroma, infection, and very seldom pneumothorax. This is a case of dehiscence treated with lipofilling. We obtain the healing after several sessions. This is a case of a patient of 70 years old that underwent 20 years before to mastectomy and radiotherapy. We obtained the healing of the ulcer after 4 lipofilling sessions. This patient was a 36 years old woman who underwent to left mastectomy and reconstruction for ductal cancer and right prophylactic mastectomy. As you can see in the left picture, he showed some deformities in contour and shape. And if you see look at the right picture, the final result was very, very good. Last case, 42 years old patient that underwent to right mastectomy with simultaneous expander implantation. In the few months after the intervention, he presented ischemic skin, a very important capsule contracture. We treated her with 5 interventions using lipofilling, and you can see in the right picture below the final result was good. What are the current issues about this technique? The first, the obvious, is filler durable, is an effective technique. The second, is it oncologically safe? And the third, is there any issue about breast imaging? About the first question, this is a recent meta-analysis, systematic review and meta-analysis The authors showed a gradual decrease of initially grafted volume to about an half at long term. We can consider this an half of the graft that we injected can go to resorption. Another evidence that was that most cases require multiple sessions, less in breast conservative surgery deformities compared to all other deformities. Excuse me. Second question: is it oncologically safe? Is a very hot topic in literature. This question. I selected two papers. This one published on the breast, where the authors show that there is a contradiction between experimental and clinical findings, but clinical studies fail to point out a significant increase in local recurrence rate in patients who received fat grafting. The second, published 2 years ago on anti-cancer reserves, a meta-analysis that demonstrates that lipofilling is an oncologically safe procedure to be incorporated into breast reconstruction following either mastectomy or breast conservative surgery for breast cancer. However, and you can find this phrase in all, this complex in all the papers, all the studies about this issue, follow-up is recommended, and in the future we need more adequate and powered controlled clinical studies to fully understand the long-term outcomes. The last question about breast imaging. And the first study was compared, lipofilling was compared to reduction mammoplastic, that as you know is a widely accepted procedure, and the results was that where the fat graft into the breast produces fewer radiographic abnormalities with a more favorable breast viral score compared to reduction mammoplastic. The study below is an Italian study published by a radiologist group. They observed that normal findings due to lipofilling are better identified by ultrasound, and the pathological findings are best identified using magnetic resonance imaging. Liponecrosis most frequently occurs when large amounts of fat are injected, as you say before. In the author's experience, lipofilling does not interfere with breast cancer early diagnosis. Thank you for your attention.
One question, if you please. About the case you do prosthetic reconstruction and reduction of breast on the other side. The case you do prosthetic augmentation on one side
okay.
and the reduction of plastic on the other side.
Was not the reduction was very few reduction. It was a lifting overall.
It's always with the prosthetic rejection only cup B.
There was an amount of fat excited, but it was mostly a symmetrization.
Yes, you do reduction of blast with the prosthesis or delayed?
First of all, I didn't show you all the pictures. In the first intervention, we placed an expander on the left.
Expander for radiotherapy, chemotherapy, and then you put the prosthesis. When you put the prosthesis, you do reduction of plastic with immediately or delayed 4 weeks?
No, after about 1 year ago, after expander placement, we made the substation of expander with definitive prosthesis and symmetrization at the right.
The second question, do you study vascular epidermal growth factor?
You study, excuse me?
Vascular epidermal growth factors with the injected fat on its impact on oncologic safety later on after many years?
as you show in the last slide, there is a large debate about this, the
Yes,
potentially oncological risk in the lipofilling. We can say that the results are not so clear in the literature, but in our experience, we've never experienced a local recurrence after lipofilling, either
No
in
recurrence at all.
conservative or
Yes.
either in mastectomy.
How many years of follow-up?
Eh?
How many years of follow-up with this?
In this case, the first intervention of about that patient was 8 years ago. The first 8 years ago.
Yeah, thank you. Excellent.
But when we was talking to you, the following years there was other 6
Formal clinical
interventions.
trials
And
will be
5
applied. Yes,
lipofilling.
yes, later on.
Okay.
Yes, thank you. Thank you. Very well.
Maybe one more question, please.
I'd like just to thank you for this nice presentation. But for fat injection and breast, there is a lot of debatable issues. Number one, if we are just taking the fat out, they said that it is better to do it by the dry technique because the wet technique and liposuction will give you osmosis and rupture cells. So you have more necrosis. Repeat, please. If there's 2 options to take liposuction for fat grafting, either dry technique or wet technique. But the better is the dry technique because the wet technique will do osmosis and rupture of cells. So it leads to more necrosis later on, more of volume loss.
They take at the beginning of our experience, we prefer to use local anesthesia and sedation. Okay, but we encountered the problem that the trouble that a patient, in most cases, a lot of pain in abdomen in the donor site. So actually, we prefer the general anesthesia without using local anesthesia in the donor site. But I can say after 10 years of experience that after the centrifugation of lipoaspirate, the result is the same. So the technique doesn't affect the final results of the aesthetic results of the technique. Is a choice that is derived from other questions, especially about pain or tumescent in the donor site. Thank you.
And regarding the total volume needed for the lipofilling, total volume, it is multiplied by 10 or multiplied by 3. If I need 10 cc or 100 cc fat defect volume to be injected, should I? Yes.
A total volume. You mean reconstruction using fat graft only? We try to perform this reconstruction in selected patients with small or medium breast size, small size. The problem is that there is the technique needs a lot of sessions to be.
The drain fluid with a greater numbers of granulocytes and monocytes than lymphocytes. So it differs from the lymph that contains lymphocytes greater than granulocytes and monocytes. Also, biochemical analysis of the drain fluids proved that it is not a lymph. It's an inflammatory exudate, as it revealed higher content of albumin, globulin, and cholesterol in the drain fluid than in lymph. Causes of seroma. Post-mastectomy seroma, literature concluded that there are 2 main causes of post-mastectomy seroma. The first one is the creation of post-operative dead space. due to operation dissection and the prevention of its obliteration post-operatively. The second cause is transection of the lymphatics and the prevention of its early sealing post-operatively, as in case of electrocautery in the modified radical mastectomy. Risk factors for the incidence of seroma: 1 meta-analysis, 51 randomized controlled studies, 7 prospective studies, and 7 retrospective studies involving 7,300 cases throughout the past 20 years were revised for formal appraisal and inclusion in this review. They concluded that there is no single factor is responsible for the incidence of seroma after breast cancer surgery. Seroma incidence is a multifactorial, and we will summarize these factors as possible. First, patient age and seroma. In the literature, seroma formation after mastectomy, it was found that patients older than 45 years with hypertension are at a greater risk of developing seroma than younger patients without hypertension. Also, the decrease in the holistic properties of the overlying skin flaps at older age may increase the incidence of seroma formation. Methods of dissection and seroma formation. In the literature, scalpel versus electrocautery in modified radical mastectomy, out of 49 consecutive mastectomy, 24 patients were operated by conventional scalpel and 25 patients were operated by electrocautery. There were no difference in the wound healing. However, the electrocautery dissection may increase the incidence of wound complication like cellulitis, infection, flap necrosis, and seroma formation by 44%. The seroma formation incidence is about 30% in electrocautery dissection and 9% in scalpel dissection. The wound complications with electrocautery was due to increased thrombosis of subdermal vessels, leads to relative ischemia of the flaps. The study modified radical mastectomy using harmonic scalpel shows that the thermal injury with harmonic scalpel is less in comparison to electrocautery. The harmonic scalpel cause breakdown of hydrogen bonds and form a protein coagulum, which occlude the vascular and lymphatic channels. The literature show also that the blood loss and drain stay days are markedly lower in harmonic scalpel, so the operative technique using the harmonic has the least incidence of seroma formation. Extent of mastectomy and seroma formation. Seroma formation after breast cancer surgery, incidence and predicting factors. This review article has demonstrated that modified radical mastectomy increased seroma formation as compared with simple mastectomy. However, no association was found between preservation or removal of the pectoral fascia and seroma formation. In addition, it shows that immediate reconstruction following a mastectomy decreased by far the incidence of seroma formation. Axillary dissection and seroma formation. With respect to axillary dissection, the study seroma prevention following axillary dissection in patients with breast cancer conducted on 92 women with breast cancer indicated that the number of removed lymph nodes doesn't influence seroma formation. Similarly, 3 studies have demonstrated that the extent of axillary dissection not influence seroma formation. On the other hand, Borosho-Tham et al. Has demonstrated that central lymph node is associated with clearly less seroma formation than conventional axillary dissection. Relation between drain stay and seroma formation. We have 2 types of drains, which are passive drains and active drains. In the literature, the factors that affect drain indwelling time after breast cancer surgery, the active drains are better than passive drains, as the former has a shorter duration of drainage, lesser drainage volume in the first 48 hours post-operatively. The longer the time of the drain removal, the less incidence of post-mastectomy seroma, but early removal can increase the seroma risk. And out of 91 women with breast cancer included in the literature, it concluded the ideal timing for drain removal is when the drainage volume is less than 30 to 50 cubic centimeter per day. A randomized controlled studies, short versus long-term post-operative drainage of the axilla, held on 100 women, 50 patients with early drain removal, 50 with late drain removal. On the contrary, this literature shows that the timing of drain removal has no influence on seroma formation. Moreover, no significant difference was demonstrated in the rates of infection between early and late drain removal. A study was conducted to compare the amount and the duration of drainage between half versus full vacuum suction drainage following mastectomy. There was no significant difference in the incidence of seroma in both groups. There was a significant reduction in the total hospital stay in patients with half vacuum suction drainage system as compared to the full suction drainage.
In conclusion, يا دكتور. In conclusion.
Conclusion, there are many factors affect seroma formation. So there are many factors of seroma formations. These factors including the age of the patient, method of dissection, extent of mastectomy, total number of axillary lymph node excised, drainage stay period, the use of pressure garment, the buttress suture technique in conservative breast surgery, early active shoulder exercise postoperatively, the effect of autologous plasma leukocyte enriched plasma, the effect of fibrin sealant and tissue expander. Take home message: prevention trials for seroma, usage of ordinary scalpel, harmonic scalpel, or ultrasonic scissors has a little risk factor for seroma formation. Delayed removal of the wound drain when the dairy output is less than 30 cubic centimeter. Early breast reconstruction, especially in the same setting of mastectomy, using pressure garment. Early postoperative, also considered as a method of seroma prevention. Buttress and tacking sutures after axillary lymph node dissection. Delayed active shoulder exercise at the site of the operation, 5 to 7 days postoperatively, with only daily activity in this period. The site and the size of breast mass, previous biopsy or neoadjuvant, blood loss or transfusion, operative time, surgical skills have no available evidence on the risk of seroma formation. Thank you.
Professor Muhammad, introduce the coming lecture.
The other speakers, Dr. Ashraf Abdel Hamid, Dr. Ayman Abu Shmila K. The next speaker will be Najla Azhar from Saudi. She's speaking about oncoplastic and reconstructive surgery in breast cancer, how we do it. How we do it in Kifaf? Okay.
دكتور good luck.
Okay, شكرا. بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته. It's my pleasure to be here today. Thank you for the society and the chairperson. I'm Dr. Najla Azhar. I'm a consultant breast surgery from King Fahd Armed Forces Hospital in Jeddah. And today I will talk about the oncoplastic surgery in breast cancer, how we do it or how I do it in our hospital. As you all know, year by year, breast cancer increasing in incidence. Last year, about 2.1 million cases of breast cancer were diagnosed. Our share as Saudi Arabia from this number is 3,629 cases, and it was on top of all cancers. What about my hospital? We diagnosed about 150 cases till mid-2018 from 2014, and I assure you that it's reached to 200 cases by early 2019. What is interesting from this series that, as you all know, breast cancer worldwide increasing incidence by increasing age. But we found in our series that the most common age-related breast cancer were between 45 to 59 years. It's about 43.3%. And the other interesting point that the patient between 30 and 44 years, I mean the young age patient, we had also a good number of them. The surgical procedures done in King Fahd Armed Forces Hospital range between two things, as we all know as breast surgeon, is the breast conservative surgery and mastectomy. And this is, as we know, is the same in the result as disease-free survival and overall survival. What we have from Milan trials. So as you see here in this graph, still mastectomies in our hospital higher than the breast conservative surgery, and this is due to many reasons of locally advanced disease. We have patients still, we have unresponsive tumor to new adjuvant, so unfortunately we have to take them in the middle of the treatment. We have also a good number of multicenteric disease or small-sized breast. And also recently we have many cases of inflammatory breast cancer. 4 patients we diagnosed from 2014 with breast cancer in pregnancy, and we are still doing palliative surgery for a patient with stage 4 breast cancer, because we believe that those patients will benefit from mastectomy as palliative, because it can increase their incidence of overall survival. What about the axilla? As you all know, the purpose of surgery in the axilla, it's only to let us know about the staging of the patient. So by 2003, when Milan released their conclusion of the equality in disease-free survival and local recurrence between the sentinel lymph node biopsy and axillary lymph node dissection, they started this by 2005. And in our hospital, as you can see in 2014, the numbers of sentinel compared to axillary dissection were really low. But it started to be increased by 2016 and 2017. And we do this for patients with early breast cancer, nodal negative disease, and clinically negative lymph node. The oncoplastic surgical technique aimed for a patient with a small monocentric or unifocal tumor, and when we have no nipple areolar involvement, and it's always the choice favorable by young women. I classified, or breast surgeon in generally classified into level 1 and 2. What I mean by level 1 oncoplastic technique, here we have to only take less than 25 of breast volume, and when we do it, we have to put in our mind that the nipple areolar complex should be adjusted at the same time, and this is done as here we can see. If we have a tumor in upper outer quadrant, we have to do our dome adjustment in the opposite side. And if it is in the inner upper quadrant, so I go to this side with deepithelialization of the skin and then undermining of glandular tissue or the skin, and do our reshaping. Always remember that skin incision in the breast should be go with the creasal lines. But my preferred incision is the circumareolar incision. And then recently, from the experience of most of the breast surgeons, we found that the radial incision, especially in tumor 3, 9 o'clock or in the lower quadrant, will be really have a good result with the radial incision. Inframammary incision also, it's a good one. And in general, if you don't find one of these incision, you have to go with the creasal line and over the tumor. I will show you some of the cases I did in the last few years. The first one, she's 35 years old. She had the tumor in the upper inner quadrant. Her clinical T1 size of the tumor, clinical nodal negative, metastatic 0, invasive ductal carcinoma, grade 2, ER/BR positive, HER2 negative, and Ki-67 80%. This patient I plan to do for her, because her tumor in the upper inner quadrant, to deepithelize the dome on the opposite side as you see. Here we resect the tumor and then undermine the skin and some of the glandular tissue. And never forget to clip the tumor cavity. This will be a big help for our radiation therapist. Here I finished with a closure mastopexy, and you can see the sterile strips in the axilla. I went for this patient to do the sentinel lymph node biopsy with blue methylene blue technique, and it was negative, so I didn't do any axillary dissection. Not only that, I went to the other side and I did dome mastopexy to reach a good cosmetic result for this patient. Here we close the other side, and this is the patient 2 days after surgery, and here's the patient 2 weeks after surgery. The second case, she's the youngest patient we diagnosed in our hospital, 25 years old, with right upper outer quadrant, clinical T2, clinical N0, M0. Again, as you know, the most common type is invasive ductal carcinoma, grade 3 ER positive, BR negative, HER2 negative, and Ki-67 were more than 80%. For this patient, I decided to do the dome mastopexy with lateral extension. And really, I took this idea from Dr. Mahmoud Al-Thamir from the Memorial Cancer Center. We met with him in February in Dubai, and he gave us an oncoplastic course about his experience with this incision. So when I went back and I had this patient, I think, why not to do it? But I did not really I didn't take any scan because the tumor was deep. So I did this superior dome deepithelialization, as you can see. This is the resection of the tumor, and the sentinel lymph node, as you can see in the other picture. Really, the tumor was interested because it's came as capsulated, which we find the capsulated tumor more with the benign disease. And here again, I learned one more thing from him, that I didn't only clip the cavity of the resection, I also clipped the margin. And I will continue to do this because it will be great help for all surgeons when they want to go back and do re-excision if unfortunately their margin came as positive in the permanent histopathology. So we closed our incision and we put a drain. So this is the patient pre-op, and this is the patient 2 days post-op. What about the level 2 oncoplastic technique? In this technique, we have really to have a good cooperation with our plastic surgery team, because we do this if we have a patient with macromastia and we need to resect the tumor of many reasons. First of all, the patient may give you the symptoms of back pain, neck pain, and she really want to relieve also from this symptom at the same time the breast cancer. Also, if we need to take a segmentectomy, not only tumorectomy, and we need to remove more than 25% of the breast tissue. And it's when we do this, we have to do it by bilateral reduction mammoplasty and resection of the tumor. This will give us a good cosmetic result, and at the same time we are not compromising our oncological outcome. So I have a patient here, 43 years old. She had a right breast mass in upper outer quadrant. It was T3 and clinical node negative, M0, histological invasive ductal carcinoma, grade 3, triple negative, Ki-67, 80%. For this patient, we downstage her with new adjuvant, and fortunately for her, she had a really good response. So by the end of the 4th cycle, clinically and radiologically, we found out that more than 50% of the tumor is reduced in size. So here we have to all know and remember, we have to apply a clip for the tumor, anticipating that this tumor will completely having a complete pathological response. And this is what really happened to this patient, because after the 8th cycle, no palpable mass were found clinically or radiologically. So we plan to take her with her desire to have a reduction mammoplasty because of the size and favoring of complete pathological response and no palpable mass. We plan for bilateral reduction mammoplasty at the same time. So how we do it? We first wire the clip in the center of the tumor in the morning of the surgery. And this is the resected tumor. As you can see here, this is the clip in the center of the tumor. We confirm it by intraoperative X-ray of the specimen. And this is the patient post-operatively. This also, the patient had a benefit of sentinel lymph node biopsy, and this is the recent recommendation from the International Oncology, NCC, or the American Society of Breast Surgeons, that if we have the complete pathological response and give the patient chance to have a sentinel lymph node biopsy. So I did it with their recommendation of dual technique and to take 2 to 3 lymph nodes. And here you can see I used this gamma probe after we inject in the nuclear department the technetium-99. At the same time, after induction, we inject the patient with methylene blue. And here we can see 2 lymph nodes. Actually, we took 3 lymph nodes out and were all negative. So this patient had a chance, no dissection of the axillary lymph node. So in summary, breast cancer is the leading type of cancer in Saudi Arabia in terms of the number of cases diagnosed in 2018 by the WHO. In our hospital, breast cancer patients between 45 and 59 years old are on top of the list as age-related breast cancer diagnosis. The oncoplastic technique level 1 and 2 in early breast cancer is a safe surgical option with a good cosmetic and oncological outcome. Please remember, always take a picture as a breast surgeon pre and post-op, and when you want to plan for level 2 technique, do a good cooperation with your colleague in plastic surgery because they are the key of success. Thank you.
Professor Zainab will introduce the next speaker. Sorry for you.
Thank you very much, Dr. Najla. So moving to the other speaker is Dr. Ashraf Abdul Hamid. Dr. Ashraf is going to talk about phyllodes tumor of the breast. The challenge persists. Dr. Ashraf.
First, I thank Mr. President of the conference for this nice meeting and inviting me to present my lecture. Thank you, Mr. Chairman. Dear professors and colleagues, my talk today will be about phyllodes tumors of the breast, a review of 99 cases in 10 years. First, I will show the bounds that I will talk about, which include aim of the work. The results include a clinical presentation of the patients, radiological investigations, a simple algorithm for proper management, the different treatment modalities, the post-operative morbidities and mortalities, and the pathological subtypes in the post-operative results, and recurrence in the follow-up period, and last, the recent guidelines and conclusions. Our study was a cohort retrospective study was undertaken in our surgical department in the National Cancer Institute, Caire University, during a period of 10 years to review the surgical management of phyllodes tumors of the breast. Out of 99 patients, the median age of the study was 45.5 years, and we had 51.5% of the patients presented with benign phyllodes tumors. Borderline disease was observed in 32%, and malignant phyllodes tumors was in 16% of the patients. Fluid tumors account for fewer than 0.5% of all breast malignancies. Regarding the clinical presentation, fluid tumors are identified as breast mass or an abnormal mammographic finding. On examination, most of the patients have a smooth, multinodular, well-defined firm mass, which is mobile and painless. The tumor size was variable, ranging from 1 to 20 centimeter. Regarding the tumor site, the commonest site was in the left breast in 62.5% of the patients, followed by 25% of the patients occurred in the right breast, and bilateral disease was observed in 9.3% of the patients. Regarding the radiological investigations, the main radiological tool were breast ultrasound and mammography, followed by CT chest, especially in malignant fluid tumors to exclude pulmonary metastasis in 10% of the patients. Fine needle aspiration biopsy was associated with high false negative results. So core needle biopsy is the preferred method of making the diagnosis. And if you have if the core needle biopsy is indeterminate, you will go for the excisional biopsy, and it will be necessary to make the diagnosis. This is a simple algorithm. If you have a biopsy proven fluid tumors, you should resect the tumor with clear margins and follow up these patients every 6 months. This figure showing the different treatment modalities. 86% of the patients underwent wide local excision, 9% underwent simple mastectomy, especially in large breast tumors, 3% of the patients underwent modified radical mastectomy, especially in patients presented with positive axillary lymphadenopathy, and oncoplastic breast reconstruction and contralateral reductionoplasty in 3% of the patients. In our study, the positive margins were detected in 6 patients in the surgical specimen, and these patients re-excised, the tumor re-excised again with wider margins in the operating room. In our study, we have 4 patients presented with metastatic axillary lymphadenopathy, 4% of the patients. Regarding the post-operative morbidity and the mortalities, we have not post-operative morbidities, but we had only 1 case of mortality. These patients had malignant fluid tumors and presented with bilateral pulmonary metastasis in the follow-up period, and these patients died from respiratory distress and respiratory failure. Regarding the chemotherapy, we had no cases received neoadjuvant chemotherapy, but we had 7 patients received adjuvant chemotherapy in the form of 6 cycles of FIC, and 16 cases received adjuvant radiotherapy. The adjuvant radiotherapy for fluid tumors is controversial, but some data suggest that adjuvant radiotherapy should be considered for patients with malignant fluid tumors. The benefit of adjuvant chemotherapy is controversial, but based on limited data and experiences in soft tissue sarcoma, adjuvant chemotherapy should be administered only for a minority of patients with large tumors more than 5 cm, high risk or recurrent malignant tumors, and only after discussion with the patients about the risks and benefits of the treatment. In our study, no patients received hormonal therapy. The recurrence after surgery, we had 11 patients. Regarding the recurrence after surgery, we had 11 cases after surgery had recurrence, 9 of them with local recurrence, and 1 case of pulmonary metastasis and 1 case of bone metastasis. So in the local recurrence, you should resect the positive margin with 1 centimeter margin, and if the margin is still positive, you should consider for mastectomy and adjuvant radiotherapy. In the cases of systemic recurrence, usually pulmonary or skeletal metastasis, you should consider for chemotherapy. This is the last NCCN guidelines 2018 in the management of fluid tumors after history and physical examination, ultrasound and mammography. If you have a fluid tumor in the biopsy, benign, borderline or malignant disease, you should do wide excision of the tumor without axillary staging. In the form of the tumor recurrence, if you have a non-metastatic disease, you should re-excision of the tumor with wide margins without axillary staging and consider post-operative radiotherapy. And in metastatic diseases, you should follow the principles management of soft tissue sarcoma. The prognosis of these patients, especially with, in benign and borderline tumors, are cured with surgery, and the survival rate of malignant fluid tumors is reported 60 to 80% at 5 years. So I can conclude that different surgical modalities are considered the main line of management of fluid-based tumors. Wide excision means excision of the tumor with the intention of obtaining surgical margins more than 1 centimeter. Local recurrence in non-metastatic disease can be treated with re-excision with negative margins without axillary staging and consider post-operative radiotherapy. Axillary lymphadenectomy is not a role in the management of breast fluid tumors, and metastatic disease of the breast fluid tumors should be treated and following the principles of soft tissue sarcoma. And thank you.
Perfect time. Thank you. My pleasure to introduce my professor Omar Farouk from Mansoura. Professor Omar Farouk, partial breast reconstruction. No. Hawaii latissimus dorsi flap is the queen of methods of breast reconstruction. I agree with you.
بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته. First, I'd like to thank Mr. Chairman, our professors, our colleagues. It's my pleasure to be here to discuss this question, why latissimus dorsi is the queen of methods of immediate breast reconstruction in our community. When we discuss this question, this does not mean we canceling or omitting other methods of reconstruction. We have many methods. Each method have advantages, disadvantages, indications, and contraindications. Even we have rate of complications and rate of risk factors, and even rate of failure with implant-based reconstruction, even in large, well-occupied and centers like Gustave Roussy, and radiotherapy always standing beyond the complications of immediate breast reconstruction. So why again latissimus dorsi? According to Delay and Hocock from Milano in 2013, they stated that this flap is the flap of choice because it is safe, reliable, could be used in slim or overweight, could be used in delayed, immediate breast reconstruction, either total or partial. The second indication, it is in the presence of risk factors and comorbidities like nicotine abuse, diabetes mellitus, obesity, which are conditions inadequate for microvascular reconstruction. The use of latissimus dorsi is a good choice. The third one, after partial mastectomy or in conservative breast surgery for outer quadrants in small breast, we can use the latissimus mini flap, like in this case, this small breast. After resection of the tumor with safety margin, we can use the LED mini flap for immediate breast reconstruction with good outcome. The fourth indication for coverage of an expander or implant in situations in which the EDM or microvascular techniques are unavailable or local tissues provide insufficient implant coverage. The fifth indication, previously irradiated patients undergoing completion mastectomy, in which we can't use the implant, which is contraindicated. And lastly, salvage surgery after failure of other methods of reconstruction. We have very rare contraindications lesions of both latissimus dorsi, pedicle, and serratus anterior, congenital absence, previous axillary surgery, which may compromise the vascular blood supply, which is the most important one, poliomyelitis, and lastly, if the patient refuses a scar in the back. So we have many advantages of latissimus dorsi. Versatile, reliable, allow both immediate and delayed reconstruction, easy to harvest, minimal donor site morbidity comparing to other methods. For example, TRAM, it offers shorter operative time, rapid recovery, and less blood supply. And lastly, hidden back scar. The most ideal breast for using latissimus dorsi is the small to medium size or medium size breast, like in this patient. We can use latissimus dorsi for total immediate breast reconstruction easily with good cosmetic outcome. We prefer to do inferolateral incision, which is a hidden scar. We can do resection of the whole breast parenchyma with the axillary section, and this photos after 6 months, and here after 1 year, and after 2 years with good cosmetic outcome. The same patient after 3 years. Most of Egyptian ladies prefer to do just one stage. They don't prefer multiple operations. So this is a challenge in conservative breast surgery. So when we facing some predictive factors for positive margins, like in this case, partial response after new adjuvant therapy with DCIS, so we should put in mind that we can turn to mastectomy if the margins are positive, like in this situation. Nipple sparing mastectomy easily done with immediate breast reconstruction using latissimus dorsi. Another case of DCIS, breast conservative surgery, shows that persistent infiltration of the safety margin. So we had turned the operation into nipple sparing mastectomy, and also the nipple areola complex infiltrated by tumor, so it was turned to skin sparing mastectomy with immediate breast reconstruction using latissimus dorsi. So what about the large breast? It does not represent a contraindication. We can do extended latissimus dorsi, and on the contralateral side we can do reduction mammoplasty and mastopexy, like in this case left breast multicentric tumor. We have designed the skin-reducing mastectomy with superior based pedicle for the nipple areola complex, and after resection of the whole breast parenchyma, we add the latissimus dorsi for total immediate breast reconstruction with reducing of the skin envelope, or what is called skin-reducing mastectomy. And on the right side, we have reduced the breast by superior pedicle-based maneuver. So we have many fatty extensions of the latissimus dorsi. These zones are reliably vascularized by muscular perforating pedicles. We have 6 zones around the latissimus dorsi that can extend the volume of this flap. Our professor, Dr. Adel Denewar, and our Mansour University team have developed since 2007 the added vascularized chest wall fat, which add another layer in continuity with the latissimus dorsi that can produce larger volume of reconstruction. And recently in the literature from UK, the Dixon and his team developed a lipo-filled extended latissimus dorsi flap. They filled the latissimus dorsi, the skin envelope, even the pectoralis major muscle with fat, to increase the volume of reconstructed breast with good cosmetic outcome. And they concluded it can avoid the requirement of implant. Although they ask this technique can be alternative to perforator-based free flaps, and comparing to DIPE, it may has the benefits that shorter length of hospital stay and less cost. Also, they still ask why implant-based breast reconstruction is still predominant, and maybe the appetite of both patients and surgeon for non-microsurgical, non-autologous reconstruction, and with technical refinement, the use of implant may become unnecessary. But we have some disadvantages of latissimus dorsi flap. The most common is back seroma in literature. It varies from 6% to 80%. It causing patient discomfort, wound infection, wound adhesions, and back flap necrosis. We have many methods to overcome, but no consensus about these methods. We have some risk factors like high BMI, large flap of reconstruction, advanced age. Another article discussing this issue concluded also PMI remain a significant factor. Receiving of selective serotonin uptake inhibitors, post-operative hypertension, hypocalcemia, and reduction of hemoglobin levels before versus after operation. The second disadvantage is donor site scar and flap contour defects, which can be avoided by strict dissection following the subcutaneous plane in the deep aspect of the fascia superficialis. Care is to be taken not to render the skin ischemic. And lastly, we should do debridement of the wound edges, which is very important to prevent wound adhesions. The third disadvantage is in very slim patients, the volume of the reconstructed breast may be insufficient or ongoing. There is a marked atrophy of flap, and the classic solution to add implant or alternative solution is to do promising lipofilling. And finally, the possible shoulder impairment, especially weakness in arm extension and internal rotation, and some acts may be hindered like swimming, rowing, cross-country skiing, or mountain climbing, and the physiotherapy may be acquired to restore full shoulder mobility. This recent article discussing this issue and concluded that the majority of patients may recover from this disability, and the disability-free percentage changes depending on whether or not the patient have practiced sports. Our center in Mansoura University have developed the usage of latissimus dorsi since 2004. It is long journey, including international publication, book share, and international conferences, prizes. However, we have more than 420 patients with immediate breast reconstruction, with most of these cases showing excellent and good cosmetic outcome after 6 months with the skin sparing mastectomy, nipple sparing after 3 years, after 6 years. It is long journey, but we have some complication. The most common complication in the reconstructed breast is radiodystrophy, and again radiotherapy standing beyond most of complication of our cases. It accounts for about 12%, and seroma in the donor site account for more than 23%, and I think it is more innocent than complication. Lastly, what about the survival? When we discuss the issue of survival, this meta-analysis recently published concluded that there is no significant differences in overall survival and the disease-free survival and local recurrence between the patient that have immediate breast reconstruction, whatever the methods, either latissimus dorsi or implant or whatever, versus those who did traditional mastectomy. So immediate breast reconstruction using latissimus dorsi is safe, and immediate latissimus dorsi based either partial or total breast reconstruction, as so often in oncoplastic breast operations, frequently complex, but careful patient selection is the key to success. It allows, in most cases, a single-stage, totally autologous reconstruction with a satisfactory aesthetic result, accepted morbidity, and least cost. In addition, local recurrent rates, the overall survival were similar to traditional modified radical mastectomy. So latissimus dorsi flaps could be considered the queen of methods of immediate breast reconstruction in our community. Thank you.
Thank you, Professor Omar, the king of latissimus. Dr. Yahya will introduce our great Professor وليد النحاس وختامها مسك.
منين يبقى منين؟ ده بيقدم
Professor Dr. Walid bin Nahas is going to present us a talk about partial breast reconstruction after conservative breast surgery, small and medium-sized breast. Thank you, مقدمة.
Mr. Chairman, thank you very much, my professors and my colleagues. My talk today is about partial breast reconstruction in a small and medium-sized breast. As we know all, the female breast has always been the symbol of femininity, and as a consequence of earlier diagnosis of breast cancer, the validity of conservative breast surgery is beyond the question. We cannot ask now about the validity of conservative breast surgery. As we know all, the contributors to aesthetic outcome is the tumor size and the proximity to the areola or tumor to breast volume, which is the most important. Sometimes there is a small tumor with a small breast, but the result, if we will proceed for conservative, will result in a very bad result. The most important factor, as all we know, is the breast size or the tumor to breast volume. It must be also borne in mind that poor initial surgical result is only usually worsened by subsequent treatment, radiotherapy and chemotherapy. And we cannot say the radiotherapy is always responsible for our bad result. Our bad result will start by surgery and then will be worsened by the radiotherapy and the chemotherapy. The volume displacement techniques in small and medium sized breast, if we remove a large amount of breast tissue, it will result in a very bad result, as we can see in these pictures. And so the classic treatment for treatment of breast cancer in small and medium sized breast is to remove the breast as a whole and reconstruct by latissimus, implant or TRAM or any method of breast reconstruction. But there is a question: if I have 50% of breast tissue is normal, with normal shape and sensation and movement, why I will remove the breast? And so immediate reconstruction of the cavity by the options we will talk about can avoid the mastectomy in this group of patients. And so we can reconstruct the cavity of breast in small and medium sized breast by latissimus dorsi mini flap and or fasciocutaneous flaps like the LICAP or the lateral intercostal perforator flap, the anterior intercostal perforator flap, or the TDAP, the thoracodorsal artery perforator flap, and sometimes there is a research to use the omentum for partial reconstruction or even total reconstruction of the breast. The latissimus dorsi mini flap, this is used in small and medium-sized breast in patients don't want contralateral breast symmetry or implant or abdominal procedure or reduction in the breast. This contraindication for LED mini flap, significant comorbidity, division of LED muscle during a previous thoracotomy, muscle pedicle division, high risk patient local relapse, and if there is no clear margin. These patients have tumor in the upper outer quadrant, and we will start by preoperative marking of the tumor and 2 centimeters around the tumor, and then the incision is lazy S incision, start from the base, the apex of the axilla and extend to the inframammary fold, and we will mark the latissimus dorsi to maximize the amount we can use, but we should inform our patients that during surgery we can remove the nipple and the areola, we can proceed for full mastectomy or even no further surgery, because if there is involved margin during the procedure. We put the patient either on the lateral position or supine position, and then we start by developing the space behind the tumor by resection of the tumor, and then flap anterior to the tumor and catches the tumor with a good amount of safety margin, and this is the specimen and the cavity. And during send for the frozen section for margin, we will manage the axilla if there is sentinel lymph node or axillary clearance, and wait until the frozen section. And then after the frozen section, if there is clear margin, we will start by harvesting the latissimus dorsi by catching the lateral border of the latissimus, catch it anteriorly and develop space behind, and then space between it and the serratus anterior, and then free the latissimus dorsi from the same incision by cutting downward and going up, and then cut the tendon of the latissimus dorsi, and this is the latissimus mini flap, it is not all the muscle, and then fold the muscle and put in the cavity, and at the end we put a drain and we can close, and this is the final result, the filling the cavity by the latissimus mini flap. The timing of latissimus mini flap is variable. Sometimes Dixon is said that we should make it in two operations 2 weeks apart because they don't have frozen section intraoperative. By Ransiberi makes all the procedures in one stage. But the complications, donor site seroma, hematoma, depressed back contour, as Dr. Omar said before, and the most problematic complication is the back seroma. So there is a lot of people, why I will take a muscles for partial breast reconstruction if there is tissue without taking the muscle to reconstruct this cavity. And so there is the era of pedicled perforator flap in breast reconstruction. The same indications as the latissimus dorsi. We can use the TDAP, the thoracodorsal perforator flap, the lateral intercostal LICAP flap, and the anterior intercostal perforator flap, and also there is the superior epigastric perforator flap. The thoracodorsal artery perforator flap, the TDAP, this is shortly the anatomy. As we know, the thoracodorsal, there is a vertical and a transverse branch, and about 8 centimeters down to the apex of the axilla, there is the first perforator of the thoracodorsal artery, and there is first, second, and third. And we will start the procedure by detecting the site of the perforator by the hand Doppler, and then we design the fasciocutaneous, the skin puddle we will take with the subcutaneous tissue, including the perforators, and then after that we will dissect from lateral to medial and freeing just the skin and the subcutaneous tissue based on the perforator flap, and then transfer to fill the cavity, and so we can reach to a very good result filling the cavity in a small breast. Second perforator flap, which is easier, is the LICAP, the lateral intercostal perforator flap. And these patients with tumor in the lateral quadrant, by the hand Doppler, we detect the site of the perforators, and then we resect the tumors and dealt with the axilla. This is the specimen, and then we start to dissect around the design we prepare before surgery, and then dissect until we reach to the perforator of the lateral intercostal artery, and then this is the perforator as we can see in the picture, and then we de-epithelialize the skin and fill the cavity with the LICAP, and this is the patient post-operative. In the left side, this is Ransiberi, which is the father of the latissimus dorsi mini flap, and on the right side, this is Mustafa Hamdi and Macmillan, and Macmillan said that latissimus dorsi should be retired, but Ransiberi said that it's still not retired, and as my colleague Omar said, it is a queen for our locality, but one option is not suitable for all, and so as we can see, the perforators, we can use the ICAP in the lateral quadrant, but we cannot use in the medial quadrant, and the latissimus dorsi mini flap can reach to all quadrant, while the only perforator can reach to the upper medial quadrant is the TDAP, and the ICAP can reach to the lower medial quadrant. And so every case we dealt with case by case, and no option is suitable for all patients. And so if my judge is about latissimus is good, I will convince my patient to use the latissimus. And if my judge, I'm not judged by the perforator, and so I can judge my patients that and convince my patients that the latissimus is not good and use the perforator flaps. In conclusion, the oncoplastic breast surgery using the mini flap or the fasciocutaneous flap extend the indication of breast conservation therapy. And on the other hand, the duration of the intervention is lengthened, and specifically trained surgeons are required to obtain an optimal result. Thank you very much.
Thank you for Professor Walid Nahas. هنقول بقى ذا كينج اوف برفوريتور. وكومنت واحد قبل ما نفتح الدسكشن، ان ذا بيست بروسيدير in oncoplastic and reconstructive surgery is the technique that you are mastering it. The question will be opened now. Any question? انتوا عايزين تتعشوا بقى. طب thank you very much. Thank you. One question for Professor Yahya.
I would like to ask Professor Dr. Loredana, you said that you combine fat injection with expander and implant. You said one of the indications of fat injection is in combination with expander and an implant. How do you do that without piercing the implant or the expander? How do you do that without piercing the expander or the implant? I know.
I didn't understand so well the question.
You said you said that one of the indications of fat injection is you combine it with expander or an implant. So
okay, is an alternative?
Yes.
No, okay. I explained to you before that the purpose to make a complete reconstruction, breast reconstruction, using only fat grafting, okay, is in a development phase. Many authors describe this possibility. We try to, with very strictly selected patients, to do it in my hospital, but when you read in literature, you see that a few authors describe this technique always using automatic system to prepare the recipient site, to make vacuum. So, but the results are not so good for total reconstruction. And I have to say that in our experience too, the results for total reconstruction were not so good. The number of sessions to obtain a total reconstruction, even in a small size breast patient, are very high. So the concept is about me for the evidence that we see from literature that now the main indication for lipofilling for fat grafting is to complete other technique or to other technique to control shape or radiotherapy to complete other technique or to prepare because in many patients it's not possible to proceed to the placement of a expander because the quality of the skin and the thickness of the tissue is very make it impossible. So if you prepare the skin and the tissue with 2 or 3 lipofilling, after you can proceed to place the expander, and before it wasn't possible. Another main indication for lipofilling is to correct the phallus, the essence. But actually, I don't, in my clinical experience and reading all the literature, I don't consider it as a universal and an effective technique for complete breast reconstruction without using prosthesis or flaps or other techniques. Okay.
Thank you very much. Thank you.
هو بس كان تعليق للدكتوره، بس اعتقد ان هي خرجت في اللي هي السنتينال ليمف نود ان بوزيتيف اكزيلا افتر نيو ادجفنت كيموثيرابي. يعني كان في بس بعض الحالات بس ان هي يعني كان لازم نضيف ان هي 2 لو في ريسبونس واثنين وديول ميثود اند كليب ذا بري اوبراتيف انفولفد lymph node we should remove it clip or mark. يعني
This is our research recently in our OCMO. Thank you Professor وليد على الإضافة. Thank you. شكرا.